And James is loading the diagnostic catheter onto our guide wire. And we're going to manipulate this. This is called a flush catheter, an omni-flush catheter. We're going to move that up into the lowermost part of the main artery in the abdomen, the abdominal aorta. And we're going to take a quick image of the pelvis just to verify that we haven't seen any changes in the patient's inflow, the delivery of blood to the legs through the pelvis. And so we're going to center up so that I can see all the way basically down to where we access the vessel. We're going to optimize our imaging setup here, and then we're going to go ahead and do a subtraction arteriogram.
And as Dr. Tonkin is injecting, and on the screen, what you will see is actually the contrast come into the vessel and opacify the distal aorta in both iliacs. And just kind of a look to see where the anatomy is, laying out the lay of the land and preparing to go over and treat the symptomatic leg.
Right.
Excellent.
John or Dr. Tonkin has already advanced his catheter and wire from the right side of the patient over to the patient's left. And now what he's doing, if we can look at the live fluoro, he's advancing a guide wire down the patient's left superficial femoral artery. And we'll see it here in a minute. The wire, if you'll notice, has a little curve on the distal end of the wire. And he's using that curve basically to steer the guide wire down the appropriate vessel.
Let's pull that out and do a subtraction.
Cut back there a little bit from it, but the bottom line is the guide wires that we use in a particular case like this are directional. And we use directional wires because you can see from the images there are turns and curves in the arteries, and we need to be able to navigate through those turns and curves in the artery.
Well, we've got we have the sheath down, the treatment sheath now. Dr. Cleo is all the way over into the contralateral common femoral, so basically at the level of the groin. You can see the little marker tip on the end of our sheath there. We're going to leave that just above the superficial femoral. And we're going to put a distal protection filter, which is just a sort of like a little wind sock made of mesh metal. We're going to deploy that down into the popliteal artery here, kind of below the level that we're treating. And the purpose of that will be to catch any debris that might otherwise embolize to the foot during the course of our procedure. So again, I'm going to get us a subtraction image here so we can sort of, a roadmap image rather, so we can sort of get the lay of the land. There we go. And we'll take a 5mm Spider X filter, please. We're going to get this Dan, let me run this wire down just a tiny bit further there.
While John's working here, he's at a point that he's trying to cross this lesion. Two things. First, she developed a large ulceration on the right leg, as we talked about earlier, which we fixed the right leg. We've predominantly healed this ulceration, but